The site most often used for chest tube placement is the fifth intercostal space just anterior to the mid-axillary line on the affected side. External landmarks for this site include the nipple level in males, the inframammary crease in females, or the width of the operator's hand placed in the patient's axilla. If the patient's condition allows, take time to position the patient's arm above the head, don a sterile gown and gloves, surgically prepare and drape the patient's chest, and locally anesthetize the skin and periosteum at the insertion site. Make a 2 to 3 centimeter transverse or horizontal incision with a scalpel at the insertion site and bluntly dissect through the subcutaneous tissues just over top of the rib. Using the tip of a large clamp, puncture the parietal pleura above the rib and enter the chest cavity. While withdrawing the clamp, spread the tips in the intercostal and chest wall muscles to create a hole large enough to admit the operator's gloved finger. A gloved finger is placed into the chest cavity to assure that the chest has been entered and that any adhesions of lung tissue to the chest wall are swept free to allow easy insertion of the chest tube. An appropriately sized chest tube is advanced into the pleural cavity through the previously created tract and directed posteriorly along the inside of the chest wall and towards the apex of the lung until all of the drainage holes on the tube are inside the chest. A clamp placed on the tip of the tube may aid with placing the tube into the chest, and another clamp placed on the opposite end of the tube will prevent blood in the chest from draining onto the bed or floor. Fogging of the chest tube with expiration, air movement, or drainage of fluid from the chest suggest successful placement of the tube in the pleural space. Once the tube has been placed in the chest, the remaining end should be connected to an underwater seal collection device and hooked to suction. The chest tube is then securely sutured in place, covered with an occlusive dressing, and taped to the chest wall. A chest radiograph should be obtained to verify tube position, and the patient should be further monitored with pulse oximetry or arterial blood gases as indicated.